I am Amy Whitaker. I am a physician in the section of family planning, and it is my pleasure to introduce today Adam Sonfield from the Guttmacher Institute. He joined the Guttmacher Institute's Washington, D.C. office in 1997, and his current title is Senior Public Policy Associate. I had the pleasure of listening to him describe his job last night, though, and Senior Public Policy Associate sounds like a really cool job. He does a lot of cool things. He wears a lot of different hats. One of the hats he wears, he's the managing editor and a regular contributor to the Institute's public policy journal, the Guttmacher Policy Review. His portfolio includes research and policy analysis that's right on target for this conference, public and private financing of reproductive health care in the United States, the rights and responsibilities of healthcare providers and patients, and men's sexual and reproductive health. He also writes a quarterly Washington Watch column for Contraceptive Technology Update. He earned his AB, and I'm not being dyslexic, it's actually an AB, with honors in social studies from Harvard University, and a Master of Public Policy focusing on health policy at Georgetown University. So it's my pleasure, Adam Sonfield.
Hi, everyone. Yes, that's an AB because Harvard is pretentious and does everything in Latin. And if you don't say that, people have actually been there, accuse you of lying. I'm not like that. I just have to say that I always find when people read my bio, I get to compare it to everyone else in the, who's speaking, and I always feel inadequate. But that's because I've been working at Guttmacher for essentially my entire working life, and the odds are I will be working there be saying the same thing 20 years from now, because that's just the way Guttmacher works. It just sucks people in, and we stay there. For those of you who don't know us, the Guttmacher Institute, hopefully you know us through our research arm, in our New York office, and the incredible volume of research that we put out in our peer-reviewed journals, like Perspectives on Sexual and Reproductive Health. We also have a DC office, a much smaller office, where we focus on policy analysis and policy-related research and lobbying, and I do all of that. And certainly over the last couple of years, healthcare reform has been essentially my working life, where I have, read tens of thousands of pages of drafts of the bills and amendments and regulations and analysis, and as Harold has said, there have been so many different talks on the subject, and I've done dozens of them myself. And it does get repetitive after a while. And on that note, I'll be repeating a lot of the same themes you've already heard this morning, and a bit of the same information. Hopefully that will just hammer some of these thoughts home that people have. One of those themes is that, yes, I understand completely why a lot of people think the Affordable Care Act is a disappointment. I'm a pessimistic person by nature. I'm a cynical person by nature, and there are lots of flaws in here. It is not single payer. It doesn't even take us on that step towards single payer that a lot of us wanted in terms of the public option. And yeah, there's a lot of money that's going to be going towards private insurance companies, and they will still find a way to make a profit because that's what they do. And there are some big flaws for reproductive health care specifically. Susan talked about them a lot in terms of coverage of abortion, not just private insurance plans, but God knows the impact of the Hyde Amendment and expanding Medicaid to 16 million more people means you're also expanding the impact of the Hyde Amendment. And that is pretty atrocious from my point of view. And certainly the way the Affordable Care Act and the way Medicaid for years has treated immigrants in this country is just as atrocious. But at the same time, just as other people have been saying, the Affordable Care Act is almost certainly the greatest progressive achievement in Congress since I was born. The increase in access to insurance that we were talking about, over 30 million new people who will have insurance that wouldn't have it otherwise. As we know, insurance matters for people using healthcare, and healthcare matters. It's not determinative entirely, but it matters for people's health. But the ACA does a lot more than that. We've been talking about some of the better coverage and better protections in the private insurance market that are part of the ACA. Things like no pre-existing condition exclusions, and things like no gender rating, and no kicking people off your plan once you find out they're sick. These are big problems in the current insurance market, particularly if you're buying on your own in what's called the individual market, or if you're buying as part of a small company at the small group market. These are major flaws in the system today, and they will be addressed, maybe not fixed entirely, but we're going to be moving towards that under the ACA. And steps towards some of the other solutions to other really major problems in our health insurance market in terms of things like shortages of providers. There's tons of new money in here for building new community health centers, for training new physicians and new nurse practitioners and new providers at every level, to tamp down on the rising cost of care and to do better care coordination. We don't have answers for those things yet, but we have a whole bunch of different pilot projects as part of the ACA to test out different solutions to these problems and to try to move our system in the right direction. One of the things I try to point out to people is that if the only thing we had managed to do was to pass the Medicaid expansion that is part of the ACA, we would be talking about that as the single biggest achievement in healthcare in decades. And that is despite the fact that, yes, it would be increasing the scope of the Hyde Amendment, and in many states in this country, most states in this country, it would mean that abortion wouldn't be available except in the most extreme cases. But the other benefits of expanding Medicaid for healthcare generally and for reproductive health are enormous. As Susan mentioned, family planning is a required service under Medicaid. It has been since 1972. It actually is a favored service. There's no cost sharing is allowed under Medicaid for family planning services. That's true also for pregnancy-related care. And generally speaking, the package of reproductive health services under Medicaid is also pretty good when it comes to other areas of reproductive health aside from abortion, of course. And in terms of private insurance, one thing that no one has really pointed to today, which I want to just mention specifically, is that under this essential benefits package that's going to be applied to all the plans in the new exchanges and also to all the individual market and small group market plans outside of the exchanges. One of the few things we know about that right now before the regulations come out is that it's going to include maternity coverage. And right now, if you have ever tried to buy coverage in the individual market and wanted to get maternity coverage, the odds are extremely high that you couldn't find that at all, or if you did, it was ridiculously expensive and probably had exclusions to boot. Coverage of maternity care right now is a major gap for the individual market. For big employers, it has been great since the late 70s when Congress passed a law specifically mandating that large employers coverage pregnancy-related care, but there have been loopholes, and this is going to help solve some of those loopholes, I hope. And I took more time than I meant to do here, so I'm going to have to speed through some of these other pieces here. But I do want to talk through 4 more specific pieces of the ACA about reproductive health care. Combined, they probably account for maybe at most 20 pages out of the 900 plus pages in that law. But they are all of them addressing major, long-standing, decades-long-standing priorities in reproductive health. And all of them are based on decades of gathering evidence to show why these policies are important. But before I get to those 4 things, I just want to quickly remind everyone of why we're in danger of losing what we have potentially gained as part of the ACA. And the bottom line is that passing a law is not the end of the law. We have, of course, attempts to reverse the law. We have lawsuits. I don't know if any of you are keeping tabs on all the various lawsuits out there. There's a great website from Kaiser Health News that keeps tabs on these. Right now, the count is there are 2 courts have ruled that the ACA is unconstitutional. 6 others have ruled that it is constitutional. A whole bunch of others have dismissed claims for lack of standing and other things like that. We had the first appellate court arguments just this week. We are still on track for what people are expecting to be a fight in the Supreme Court in 2012 at some point, and a decision sometime hopefully then, right in time for the election or right after the election. A lot of most of those lawsuits have been around the individual mandate specifically. That's the requirement that everyone in the country have insurance coverage or else essentially pay a tax penalty. There are some exceptions to that for people who can't afford it, although of course part of the law is to make sure that almost everyone can afford it. But that's been sort of the basis of a lot of the lawsuits. It's not really clear what would happen if it's ruled unconstitutional. The whole law could be struck down. That's the way the Florida court did it. Just a small piece of it could be struck down. That's the way the Virginia court did it. We don't really know, and we don't know what the consequences would be and how Congress and policymakers and advocates would react to that. Of course, there's also attacks in Congress. The mantra has been repeal and replace. That isn't going to happen before 2012 because they don't have the votes and because, of course, President Obama would veto it. And, of course, they also haven't agreed on what the replace piece of it is. And they also, frankly, can't repeal certain of these provisions at this point. Some of them are in effect and they are popular. And some of them also save money. So you'll see that even in the House Republicans' budget plan, where they essentially strip out most of health reform and try to block grant Medicaid and do other nasty things, they are still maintaining a lot of the cost savings from health reform in their plan, because if they didn't, they'd have to find another $500 billion in savings to replace that. At the same time, Congress is going to be looking at piecemeal changes. We already talked about one of those changes they succeeded in, the tax reporting provision for small businesses that so many people hated. They're going to try to keep chipping away at the law every way they can. On reproductive health, of course, the big target is abortion coverage. Right now the coverage under health reform is, in my view, pretty horrible and has a pretty high probability of driving out abortion coverage in the private insurance industry in this country. What the House Republicans are pushing for is something which would make that even more certain. It's not certain what would happen in the Senate. It's not certain whether they can find a way to maneuver to get a straight up or down vote. That's really the game in the Senate is, do you still have that 60 vote threshold for the filibuster, or can you find a way to make it a 51 vote, 51 being the majority? And if they can do that, we're not really sure where the vote outcome would be at this point. Further, they're going to keep attacking the funding. Everything they can do to attack individual pieces of it, like that prevention fund or the funding to help states set up the exchanges. And funding to write regulations and implement the law in the first place, and to hire new staff members at the IRS to help to help implement these tax credits that are going to be subsidizing people's coverage. And the states, of course, are also taking different tacks on trying to attack this law. Some of the states are refusing to cooperate at all. Other states are doing what they can to make it as conservative as they possibly can. At the same time, there are going to be specific attacks on reproductive health, of course, abortion coverage, but other things as well we can expect. As I think other people have made very clear, that we still have a lot of work to do on implementation. This year alone, we can probably expect thousands, tens of thousands of pages of regulations coming out of the Department of Health and Human Services. And after that, you'll have a lot more implementation issues at the state level once they figure out what the parameters are that they're working within. These details really matter. Because people can screw things up intentionally or they can screw things up unintentionally. And we need to be keeping an eye out for all of that. And of course the deficits and the partisan politics generally, the broader political dynamic in this country is adding to all this concern and all this confusion. And that's probably true not just on the right but also on the left, where some of the continued disappointment and attacks on the ACA from the left has made it seem like there's no one in this country who actually likes it. That has certainly weakened people's positions and weakened policymakers' resolve. It's very difficult for Democrats in Congress who fought tooth and nail to get this passed and had to manage. Had to get all 60 people in the Senate to agree on this, despite the fact that some of the people in that caucus are far more conservative than some of the Republicans, in the Senate. And to get them all to finally agree on something was a tremendous difficulty. And now it's, I think a lot of people are feeling like they're being attacked for the work they put into this. And that certainly makes them less likely to go further going forward. So let me talk about these 4 provisions that I really wanted to focus on. One of them I will go through a bit more quickly since everyone else who has spoken has already mentioned it. This is the Preventive Health Services provision, which requires all new private insurance plans in the country to cover several packages of preventive health services and to cover them without any out-of-pocket costs for consumers. So no co-payments, no deductibles, none of that. One package was the U.S. Preventive Services Task Force package that Harold mentioned. There's another package which is recommended immunizations from an advisory panel for the CDC. A third package is the Bright Futures Guidelines for Pediatric Care, which the American Academy of Pediatrics puts out and the federal government supports. As Susan mentioned, there will be a 4th package of services coming up for women's preventive services. This is known as the Women's Health Amendment. It was sponsored by Senator Mikulski from Maryland. Certainly she and most of the supporters of that amendment expected that to include contraceptive services and supplies, among some other services that are not in that task force recommendations. The task force has only about 3 dozen recommendations right now. There are a lot of gaps, and so the idea is to fill in those gaps for women at least, unfortunately not for men. Right now, as of last September, although really this takes effect for individual plans on a rolling basis, the list of reproductive health services that are included under here is already pretty large, including cervical cancer screening, screening and counseling for HIV and chlamydia and gonorrhea and syphilis. It includes a bunch of different pieces of prenatal care, including things like folic acid supplements and smoking cessation counseling. It includes the HPV vaccine, which has been very expensive for a lot of providers to provide. It includes some pretty comprehensive counseling on sexuality for minors. And obviously we're hoping that's going to be improved upon with this Women's Health Amendment. We will find out more next month when the Institute of Medicine panel releases its recommendations, and even more after that in August, presumably, when the Health and Human Services Department makes their final determination. We still may not have a lot of that impacting women's health plans, unfortunately, until as late as 2013, just given the way the provision is structured, unfortunately. And I have to say, this is, on the contraception side especially, this is sort of the culmination of almost 2 decades of effort to improve insurance coverage of reproductive health services. We found back in '93, during the Clinton attempt to do universal health care, that coverage of reversible contraception in private insurance plans was actually quite poor. And there's been a lot of effort in the states, in the courts, in the federal government to change that through state laws, through rulings that this is sex discrimination, not to be covering contraception when you're covering other prescription drugs. And the impact has been quite effective. By 2002, we had found that most insurance plans, the vast majority of them, were actually covering a full range of reversible contraceptive methods. There are still gaps, though, in those coverage, and certainly gaps in terms of cost sharing. The cost sharing for prescription drugs has risen tremendously over the past decade. And this provision, if it includes contraception, will really help fill in those gaps. Second provision I wanted to walk through is the Medicaid Family Planning State Plan Amendments. Again, this is the culmination of about 2 decades worth of advocacy. There are 22 states already which have comprehensive expansions under Medicaid for family planning services through what is known as a waiver process. The waiver process is horrible. It takes a long time, on average about 2 years from beginning to end. Then you have to keep renewing it over and over again. There are a lot of strings attached. But at the same time, all these states have done it because these programs have proven extremely successful in terms of bringing more money into the family planning system, bringing more clients into the system, helping to prevent thousands of unintended pregnancies and abortions and unintended births every year. And as a consequence of that, end up saving the federal government and the state governments millions of dollars, hundreds of millions of dollars, actually in California, billions of dollars in money that would otherwise be spent on Medicaid-funded pregnancy-related care. The idea is to be able to say to women, right now Medicaid will cover you up to, in most states, around 200% of the poverty level if you become pregnant. And these programs allow states to say, we're going to give you the choice. If you want to become pregnant, we're happy to cover that. If you're trying not to become pregnant, we're going to help you with that too. And the Affordable Care Act makes it a lot easier for states to do that. It's now, they can use what's called a state plan amendment. The short is SPA. That's just the shorthand for that. People talk about SPAs. It's a lot easier, and this is the way the waiver process is supposed to work. You're supposed to demonstrate that that one of these changes is valuable and helpful for people and for the government, and then Congress is supposed to turn around and say, okay, everyone can now do that. That's what happened with Medicaid managed care in the past. We might not all agree on whether that was successful and should have been done. That's the way Congress has done things in the past, and that's the way they've now done it for Medicaid family planning services. So far, the federal government put out some really quick guidance in 2010. There are 4 states that have already taken up this new option. They all happen to be states that had waivers already, but we do have a few states in the pipeline, which would be new states. I think this is especially important before 2014, before all these other reforms, hit. But even after that, it might be extremely important for filling in the gaps for people who might fall through the cracks and for services that might fall through the cracks. The third provision I wanted to run through quickly are teen pregnancy prevention initiatives. Again, this has been more than a decade of effort to try to get federal funding for comprehensive teen pregnancy prevention. A lot of that stems from 1996, the welfare reform law, which essentially, for the first time, set absence-only education as the federal policy around teen pregnancy prevention, and put all sorts of new money into extremely restrictive, ideological, religiously based programs that have to adhere to this 8-point definition of what it means to be an absence education program, which includes things that are, frankly, lies. Things like absence outside of marriage is the standard of the standard of behavior in the United States. Things that just are not accurate, and actually essentially required programs to, if they were going to talk about contraception at all, to only focus on failure, because otherwise that would be somehow promoting contraceptive use. So this has been and these programs haven't been proven successful at all in terms of changing behavior and changing health outcomes. So on our side, our own repeal and replace initiative has been to repeal these absence-only programs and replace them with comprehensive sex education programs. There have been 2 new programs over the last 2 years. One of them was from the Affordable Care Act. One of them was passed separately just before that, but they're being run in conjunction with each other. $190 million new money per year for states and community-based organizations to be running more comprehensive more comprehensive teen pregnancy prevention programs. They're sort of split the money. About 75% goes towards proven programs that have a demonstrated track record. 25% goes towards programs which are promising and that you want to evaluate. They're supposed to be evidence-based, age-appropriate, medically accurate, supposed to cover abstinence and contraception, and many things beyond that. The ACA one is called the Personal Responsibility Education Program, and it really does focus on all these other life skills out there, which, as we know, are all linked together. Decision-making skills and being able to say no and be able to plan for your life. These are all things that affect not just reproductive health care, but the rest of people's lives. And these programs will hopefully be helping to provide better education across the country on these topics. The last one I wanted to mention is home visiting programs. These are not programs which Guttmacher and many of our allies on the Hill who deal with reproductive health issues have been focusing on, but there are a lot of other groups that have been for decades now. Groups like the Maternal Child Health programs out in the States and their association, AMCHIP. So the official program is called the Maternal, Infant, and Early Childhood Home Visiting Program. There are different models for these types of home visiting programs. The best known one is called the OLDS model. It's now known as the Nurse-Family Partnership, and it's been replicated across the country in lots of different states. Essentially, the idea is to have nurses or other professionals or paraprofessionals visit the homes of pregnant women, pregnant couples, or new parents, and to help talk about the importance of prenatal care, to talk about the importance of planning your family going forward, to talk about child development and education and figuring out various life skills and being able to just help be self-sufficient and to be able to, and part of that, of course, are the ideas of trying to keep people out of poverty and keep people out of the welfare system and all that. But these have been very positive influences across the country in a lot of states. And almost every state at this point has put at least a bit of money towards these, usually from various random pots of money like Medicaid or the Maternal and Child Health Block Grant. And when President Obama came into office, one of his big initiatives in his first budget was to try to replicate this and expand it so that anyone who wanted these visits, any new parent across the country would be able to have these services if they wanted them, and to put that much money into these programs. And the ACA doesn't go quite that far, but it's a pretty big down payment towards that, $1.5 billion over 5 years, and that ramps up over time. Again, it has that same 75-25 split that the teen pregnancy prevention programs have, to try to stick mostly with these proven programs, but at the same time try to experiment and find proof that other programs can be effective too. Specifically for reproductive health, some of these programs in the past have been really demonstrated to have some strong outcomes in terms of better birth outcomes, in terms of better birth spacing. I'm not sure how many of you know this, but the timing and spacing of children has a pretty profound impact on maternal and child health outcomes. And trying to make sure if you space pregnancies around 2 years or more, it can really help with things like low birth weight and preterm birth. And these programs have been proven to be successful to some degree at helping with those, as well as helping with other child development outcomes and educational outcomes and things like that. And again, this is more of a holistic approach. And I know the reproductive justice approach in many ways is a holistic approach, trying to see the links between different problems in people's lives. And this is the type of program which tries to help people address those problems, and a lot of them simultaneously. So all that said, these 4 programs are not at all without controversy, and there's controversy from both sides, from the right as well as from the left. From the right, it's pretty much what you would expect, what you hear for reproductive health services generally. There's, of course, opposition to contraception and to funding contraception, and religious objections and the desire to have refusal clauses. Obviously that's coming up right now with the Women's Health Amendment. It also comes up in terms of the Medicaid family planning expansions. And tied into that, of course, again, are trying to tie all this into abortion and to conflate family planning with abortion. And the attacks on Planned Parenthood that are going on right now. So we have those usual issues that we always have to deal with when it comes to reproductive health. We also have, for the teen pregnancy prevention program specifically, of course, you have the push for abstinence-only education has not died down, and people are trying to push to have more money go back into those programs. And of course, the more, the broad objections around, fiscal issues and having to cut the deficit, and, we don't want to be spending money on these social programs. I think some of the arguments from the left are a bit more interesting, and some of them are sort of tactical criticisms. So for instance, why was it that family planning wasn't listed specifically in the package of services included in health reform? And I went to enough of those meetings to know why they didn't do it, and I know that it was when Clinton tried to do this back in the 90s, they did list out everything in minute detail, and that became a major political vulnerability, and they decided to not take that, to try the opposite tack this time around, and to rely on the Department of Health and Human Services to put out evidence-based, guidelines for how to fill in that package. And to think that actually is a good thing, because it means it won't be a political decision, but it'll be, a scientific decision, and that may have more weight going forward if the administration changes, for instance. There are also, worries about loopholes and the timing in the preventive services provisions, and I absolutely, there are some real issues when we might not have, even if we do get contraception in that package, it might not be helping women until January 2013. And even then, there are going to be plans that are going to be able to be grandfathered plans that won't have to be subject to a lot of these new regulations for it could be years at a time. And there might be exceptions, like things like if you go out of network to an out-of-network provider, these preventive services provisions, these protections don't apply, unfortunately, under the current regulation. So those are real issues that we need to be thinking about and be able to work on. Yeah, it's true, of course, for the Medicaid expansions and for the broad Medicaid expansions. One of the big complaints about Medicaid, of course, is that Medicaid reimbursement is too low. We've heard about that already today, and that's something that, unfortunately, you need to attack at a state level, state by state, and really try to put in place mechanisms for making sure that those reimbursement levels go up and go up on a regular basis, so that they're accounting for inflation. There are also some new requirements that come with this new SPA option rather than the waiver option. Ironically, they're requirements which mean more people get covered. It means that men have to be on these programs and teens have to be on these programs, where in the past some states have excluded those groups. It means that transportation services have to be covered for women who need transportation to get to their provider. These unfortunately add to the costs, and that has made it difficult for some states to be taking advantage of this new option. Although, frankly, we've run some of those numbers, and the costs are tiny compared to the overall cost of the programs. On the teen pregnancy prevention front, there certainly are some disappointments in terms of how comprehensive these new programs truly are. Is this really the comprehensive sex education that we want? And I know it isn't what everyone wants, although it is so much closer to what we wanted than what there already. And of course, there are a few of these programs are still going to be abstinence-focused or even abstinence-only. They wouldn't be able to fit under that old 8-point definition, because there's no way they'd be able to be evidence-based and to be medically accurate and age-appropriate if they were. And there's still $50 million of money going towards abstinence-only programs that was revived as part of the ACA, unfortunately. And I don't know nearly as much about the home visiting programs in terms of the politics around that, but I will say that I know there have been some worries about whether it will be truly voluntary, worries about being paternalistic, and and in terms of being social engineering and targeting poor people. And certainly worries about things like once you invite people into your home, there are dangers about child neglect reporting and being pulled into the system inappropriately. Of course, one of the benefits is you might also find, actual child abuse and neglect, which is obviously a good thing. So let me just run through quickly, since I'm about out of time, to say that, I think in some ways it might be that from a reproductive health perspective, that it has been so long since any of us have seen a real victory on the federal level that we may have forgotten what victory it looks like. And we've forgotten that, no matter what you pass, it's not going to be perfect. And it is going to require work. There are pitfalls to avoid. You have to worry about the details of implementation. You need to watch. You need to care. You need to, help. You need to make sure that all this is happening so that these imperfect laws can reach their potential and maybe even exceed their potential. There are three big fronts on that right now. One is protecting, this new framework from the constant attacks that are going against it, and making sure that the ACA survives and that the various pieces that we care about survive. And second front on that, of course, is to make sure it's implemented in a way that helps address all these different concerns that we rightfully have about the potential pitfalls that could happen if this is implemented poorly. And the third piece of that is to keep pushing, to go further, to go beyond what Congress has passed. And when it comes to reproductive health, that means absolutely. That means trying to convince the American public that insurance coverage of abortion is a good thing. Abortion is health care. It should be covered like all other services. And that is a long haul to try to convince the American public that it is true. I mean possibly decades. And that's true also with immigration, trying to convince the American public that immigrants should have the same rights that citizens do, and that it is a bad idea to have immigrants, documented or undocumented, in this country who don't have access to health care. Even putting aside things like STIs and other communicable diseases, it's just bad for everyone. So these are long-term fights, and each of these fights are difficult, and they're difficult by themselves, but they're also more difficult in conjunction with each other. And I think a piece of that is the idea that we need to make sure that our short-term tactics, fighting off these attacks and looking at our short-term goals, doesn't conflict with our long-term strategies. I think in just two quick examples of that, one is for the ACA writ large, that we need to protect it right now while still laying the groundwork for single payer in the future, or for at least steps towards single payer in the future, and to make sure our arguments right now are not cutting off arguments later on that for those longer term goals. And that's true of abortion coverage too. Right now we are so consumed with this idea of expanding these bans to abortion coverage to private insurance. And a lot of our talk has been about how these are new and radical. And we have to make sure that while we're doing that, we're not somehow hindering our efforts to eventually repeal the Hyde Amendment. And unfortunately, a lot of the rhetoric around that has been detrimental to our long-term efforts to repeal the Hyde Amendment. When you have Nancy Pelosi and President Obama and many of our other champions of reproductive rights talking about things like, this is a health care bill, not an abortion bill, which says abortion is not health care, or we're saying that we're not touching the long-standing protections against public funding of abortion, meaning this is something we're supposed to be protecting against. That's not what they meant to be saying. These are people who support repealing the Hyde Amendment, at least in principle. But we can do a lot of damage in the long run if we're not careful. So that's what I have to say.
So we have a little bit of time for questions. If people have questions for Mr. Sonfield.
Thank you. This question may be for you or for any other experts in the audience that might know as well. Can you just clarify where we are in this law with the issue of reimbursement parity? There was some talk that Medicaid and Medicare would be linked, and therefore Medicaid providers would be reimbursed at the same rate as Medicare, and now I've heard that may be for primary care but not for other services. Does someone know where it stands? Yeah.
That was not in the final law, no. There are a few incentives for improving Medicaid reimbursement. For instance, there's like a boost to Medicaid reimbursement if preventive care services are covered without cost sharing, things like that. There are a few boosts for specific types of providers, like I believe. Sorry, it's not. It's nurse midwives, I believe, get a boost so that they're going to be at least in Medicare, so they'll be tied to private positions. But I don't believe there's much to take that out of the hands of the states, unfortunately. But if other people have more to say that I'm missing, please jump in.
No, I think it's just the primary. There is funding for the primary care providers to incentivize more primary care, but I don't think there's anything else.
Does it guarantee parity in reimbursement for primary care? Or is it?
Right.
In Medicaid and the exchange plans? Is that? Or no, I guess out of the exchange would be Medicaid. Thank you.
And I do know for that provision that OBGYNs are not considered primary care, if I remember correctly, which is one of the unfortunate gaps in that. So.
I'm too short for the microphone. I appreciate you're talking so much about abortion in the healthcare. I think a lot of times people want to shy away from that because it is such an unpopular subject, and because, like you said, we have decades of work to do before the American public can be convinced that abortion care should be covered. Can you give a little more detail about, I think everyone knows, I love the healthcare bill. I'm thrilled we passed it. I agree that it's a huge piece of progressive legislation, but I don't think there's any question that abortion providers like myself and women who need abortions have been rolled under the healthcare bus. And I think most people understand that the healthcare plan, the government isn't going to pay for it, but most people don't understand the degree to which it can, unincentivize private plans from covering abortion. And I would just like, when I talk about it, I don't have the policy background that you do, so I'd like to hear how you describe the way that will happen. So basically everyone in this room will know it and can start telling people it's more than just not covering. It's actually going to make a lot of the private companies not cover it.
Yeah, it's a complicated and controversial piece of things. Essentially people were disputing what is the precedent for federal funding of abortion, and there are sort of several different possible precedents to look at. What really happened in the end sort of follows the Hyde Amendment precedent in a lot of ways. What it says is that no federal dollars can go towards abortion coverage, but other non-federal dollars can. That's the way it works under the Hyde Amendment, that federal dollars cannot go towards abortion, but state dollars, for instance, are allowed to go towards abortion. And so there are 17 states that, at least officially, use their own money to pay for abortion under Medicaid. The way it works for the exchanges is a bit more complicated, because the idea is to try to make sure that private premium dollars can go towards abortion coverage while the federal subsidy dollars cannot. And essentially what happens, and we don't know for sure yet because we don't have regulations yet, and we don't know if we're going to get real regulations yet, as Susan was saying. It may end up being at the state level. But we will have lots of different hoops to go through to segregate out a pot of private premium dollars that will be devoted specifically for abortion from everything else that's out there. And one of the big worries is that the number of hoops that insurance companies are going to have to jump through are going to be so high that they're not going to want to do this. It's not going to be worth their effort. At least at first, the estimates are that 80 or 85% of people in the exchanges are going to have subsidies, since that really means that these hurdles can be applied to almost everyone in the exchanges and to all the plans offered in the exchanges. So what we're worried about is that there's going to be sort of a tipping point, and I think adding to that tipping point is the idea of state bans on abortion coverage. States have long been allowed to ban insurance coverage of abortion. Even before health reform was passed, 5 states already did so. We're up to 11 now, I believe. The more states you have doing that, the more likely it is that the big insurance companies across the country are going to say this just isn't worth our time anymore, particularly if they're going to get things like protests from anti-abortion groups once they find out in 2014 which plans are still covering abortion. I think we have to expect things like that. And unfortunately, we have to expect that the antis are going to probably do a better job of protesting coverage than we are going to do protesting lack of coverage, because it's very hard to convince people that they want abortion coverage in their own plan, because no one wants to think about that. No one wants to think, I might need abortion coverage at some point. You don't think about, these are unexpected events, either an unintended pregnancy, by definition unexpected, or even, worse, a planned pregnancy that has gone wrong. These are things that people don't want to think about, they want to plan ahead for, they certainly don't want to be paying money in advance for. Sorry, I know I've run over a lot at this point.